Welcome to Med Scrolls, Manchester's underground med school. This is the one-stop shop for high-yield clinical content relevant to your undergrad exams. Join me as we unravel the scrolls, one disease at a time. Welcome everyone back to this brand new podcast. I'm your host Hamza, a third-year medical student at Manchester University, and I'd like to welcome back Dr Pippa.
Thanks for having me.
So what are we talking about today?
So we're going to talk about rheumatoid arthritis, which is the most common inflammatory arthritis in the UK, and it affects about 1% of the population.
Great. Could you quickly summarise the pathophysiology of rheumatoid arthritis?
Absolutely. So what we often find is that patients do have a genetic predisposition. They may well have a family member that's been affected, and then an environmental trigger such as smoking causes a process such as citrullination, and that leads to autoantigens, and then these lead to the inflammation that we all recognise. We get activation of both the innate and the adaptive immune system and production of cytokines like TNF-alpha and IL-6, and the inflammatory response that results, unfortunately, damages joints and bone.
And what would the typical patient look like in your clinic with rheumatoid arthritis?
So rheumatoid arthritis can affect anyone, but the typical patient is a female, so more females than male, and the peak age of onset is between 30 and 50. There may or may not be a prodrome of just feeling a bit more under the weather, and then the most common presentation is of the small joints of the hands or feet being affected in a symmetrical manner.
Is there any other key presentation complaints with a patient like this?
I think what I would say about inflammatory arthritis is that because it is a significant illness, patients will usually remember when it starts, and they will usually describe a pattern consistent with inflammation. So that's pain that's worse in the morning, significant stiffness, usually lasting 60 minutes or more, and that pain and stiffness will tend to get better as the day goes on.
And a patient like this walks into your clinic. What other things are in your mind in terms of differentials?
So other types of inflammatory arthritis, particularly if they do give that history of stiffness and pain worse in the morning, so psoriatic arthritis is really important to consider. A small percentage of these patients will have a connective tissue disease like lupus, so it would be helpful to screen for other things like Raynaud's. Always think of fibromyalgia as well with early morning stiffness, because it can commonly cause this, particularly if there's a huge amount of pain and perhaps not very much to see on examination. And never miss a septic arthritis, so particularly if there's one joint that's affected or one joint that's worse, that would be an important thing to consider as well.
Great. So RA is on the top of your list of differentials with a patient. What would you be looking for in an examination?
So you need to see these patients face to face to make a diagnosis of inflammatory arthritis, and when you examine the joints, you'll be palpating them using both of your hands, and you'll be feeling for swollen joints, and that swelling is a boggy swelling. It's meant to have a texture like if you kind of squash a grape, and it would usually be tender when you examined as well, and that distribution of synovitis sort of in a symmetrical, usually fairly symmetrical manner, often affecting the MCP, PIP joints and wrists, would be highly suggestive of the condition. There might be rheumatoid nodules or other clues, or there might be psoriatic plaques or things that might send you in another direction, but the history and examination are really key to making a diagnosis.
And is this a clinical diagnosis, or would you be looking to do further investigations?
So we would do further investigations, at least blood tests. Rheumatoid factor and CCP can be helpful if positive. They don't have to be in rheumatoid arthritis, but they are useful because they can be associated with a worse prognosis, so that will help guide treatment. We would always do x-rays to look for erosions, which are helpful making the diagnosis and again have a bad prognostic implication. If we're uncertain whether someone has inflammatory arthritis, ultrasound is our go-to test.
So you've diagnosed a patient with rheumatoid arthritis. What are the next steps to treat this patient?
So it's very important to treat these patients early and aggressively. There's lots of data on this from studies such as TACORA, and we know that we need to treat them to a target disease activity score, or DAS. So treatment usually involves a combination of steroids and a disease modifying drug initially. Our go-to drug tends to be methotrexate, unless there's a reason to use something else. If that doesn't work, after regular reviews every 4 to 6 weeks, we'd add in a second and sometimes third disease modifying drug, and if that doesn't work, then we would add in a biologic drug. What we're aiming to do is get our patients into remission. That means they don't have any symptoms on a day-to-day basis and they won't develop any joint damage.
And what complications would you be worried about in terms of the treatment themselves and the condition?
Thank you. So infections, the biggest thing that we worry about, particularly with the treatments. In terms of the condition, rheumatoid is a systemic condition. People can develop other complications such as lung fibrosis or pericarditis, pericardial pleural effusions. They also have a significantly elevated cardiovascular risk, which is often forgotten about. So it needs really careful monitoring of blood pressure and sort of healthy lifestyle advice. And we do have a very holistic approach to these patients. So not just drug treatments, but also access to the multidisciplinary team. So podiatry, physio, OT are really, really important.
And any tips for undergraduate students in their rheumatology placements?
I think it's really about practice, and I think you can very often diagnose this with a good history and examination. And if you see patients you think have inflammatory arthritis or you suspect have it, please do send them to us, because we want to see them early so that we can get them started on the right treatment. It's really important.
Great. Thank you very much, Dr. Pippa.
It's a pleasure.
Thank you for listening. That's all for today's scripture. If you enjoyed this episode, follow the MedScrolls channel. Until next time, stay bodacious.